If you're listening to this on the audio version, today I'm sitting down with two friends and fellow family physicians, Dr. Rachel Weiner and Dr. Sophia Malik, at the Seattle Content Studio. This is super fun because it's our first video podcast. And we get into something I've been thinking about a lot. If you've listened to this series for a while, we talk about how our patients are carrying unprocessed trauma in their bodies. At the same time, it's been really hard to navigate what to do about it. So this is our first episode on talking about what is possible and how to be present with that kind of trauma. Outside of referral to mental health and getting that comprehensive support, I think we all have a role to play in this. We get personal about our own journeys with embodiment, disconnection, and the uncomfortable question of why we became physicians in the first place. As I said, this is our first video episode. So if you want to watch the full conversation, you can find it on YouTube. Just search Healthcare for Humans. I'm excited to be here at the Seattle Content Studio. This is kind of fun. What do you think?
Yeah, I think, I don't know, it's just fun to be with you guys. Really excited to have a conversation together. I have small kids, so anytime I can talk to adults, I look forward to that period.
Especially adults who are paying attention.
Right, yeah. And my friends. You guys are my friends.
Yeah, I'm excited for this topic. What I would love to do is maybe first do some introductions. And the question that I've been thinking about so much is bodies and embodiment in all its iterations. You know, as a primary care physician, I just feel like disembodied in so much of the work that I do. So I think that has been my starting point. So I would love to just first introductions and hear about your journey with just the idea of embodiment. Maybe that's a starting point. And then we can see after that which direction we go.
Okay, so I'm Rachel Weiner. I'm a family physician. And I am in the process of completing a training called Compassionate Inquiry. That is a kind of teaching a trauma-informed, body-based approach to counseling. So I'm getting to learn with a lot of therapists and coaches, a few other doctors. It's been a really cool space. And yeah, it's a really interesting question. I grew up in a way, both I think within our culture in the US, within my specific family culture, which is coming from a Catholic Christian background. And I think within the specific context of my family, where I think there's generations of disconnect and trauma. And I think because I was someone who was smart and did well in school, it was much easier to be in my head than it was to be in my body or connected to my emotions. And so I think a really core and early coping mechanism for me was to trust what I was thinking and be very disconnected from my body. And it's been an interesting and long journey of reconnecting, one of which I definitely still feel like I'm on. In some ways, I think probably doing yoga was one of the first invitations to really connect in my body in a different way. And that was something I started doing more regularly in medical school. So that was a really interesting balance to medical training, which is so much in our heads. I think we talk about relationship and, being human with patients and connecting, but I don't really think I remember any conversation around what does it mean to do that in an embodied way? And it's so intriguing, you're learning so much about the body, you're learning where are all these the anatomy of the body, where are all these different parts of your body, but there's no pausing to say let's think about that internally. What is it like to think about I have a liver, what does that feel like in my body? So it's just, there's an interesting disconnect there. And then I think another really important piece of my journey has been mindfulness and meditation. And so it's right after residency that I got to do my first longer meditation, sit in the Vipassana tradition, which is all about paying attention internally to your body. You're just like sitting, paying attention to your body for hours. And I think that was really challenging, but kind of a call to connection with myself. But I actually think it's really been, so I was working as a faculty for a family medicine residency program and ended up leaving that about like a year and a half ago now. And I think it's really been in this space when I've, for the first time in, I don't know, like 15 years, like slowed down a little bit and had more space and time, that I've really kind of more deeply connected. And I think in some ways I almost needed that time, because I don't think we talk about this enough. Like, healing and connecting to our body can actually be quite disruptive. And it's hard to do that when you're in the midst of your really busy job and life, because when you connect to things you haven't connected to for 30, almost 40 years, it's overwhelming and it takes space to digest and make sense of. So I've been really grateful to have just a little bit more like space and slowness in my life to be able to do that work. So
thank you. So much to reflect on there. Something that came to my mind was how bodies seem like something we have to control rather than feel or experience. It feels like we talked about your family and individual history, but it's such a cultural phenomenon. I mean, so much of, we talked about training. We've all been through clinical training, and it's like, how can I make my body sleep less and eat lunch through charting and not like remember anything that I ate? It's like such a functional thing that's sometimes, it's almost a negative thing. It's getting in the way of something that my mind wants to do. And unhooking that and thinking about connecting with that can feel scary. And, talk about disruptive, because I think sometimes I talk about the body of like, everybody wants to be embodied, right? When actually there's some phases when you're reconnecting that can be hard.
Yeah. And it was interesting that you said something that your mind wanted to do. Like, how do you know that you want to be doing that?
Yeah. And maybe this is like the continued reinforcing belief of the mind-body disconnect. There's this Rene Descartes quote of, I think, therefore I am. People heard of that, of like the original inception of how the mind and body are different. That this thought separates out everything else. And so much of our structure, culture, med school is all geared towards that from my experiencing and understanding. But I also want to hear your story of how you find yourself in your body.
How I find myself? Yeah. Well, I really appreciate what you shared, by the way, Rachel. Really made me think of like a lot of similarities, even though, we share growing up in the South, but my background is Muslim and Desi. And so it's kind of a mixed bag with some of the traditional practices or religious rituals are very body-based, but then there's others that kind of feel way more disconnected. And then growing up with the pervasive racism, which is everywhere, but especially where we grew up, that so much of how you're treated is because of the body that you're in. And for me, it was really hard to, I guess I would say I didn't feel open to mindfulness, because the way I perceived it was, you need to calm down or sit with your thoughts and just observe them felt totally, I don't know what the word is, like, it was unbearable. Like, it was totally unbearable. And so at the time, I didn't understand that there are other ways to, I needed to start way further upstream. And I personally started really going to therapy after I graduated from residency. And so you mentioned having a break from, working in a residency. And even though I was working during that time, the time requirements were so much less comparatively than when I was in training. And I had more space and more time and also more resources to go. And I originally started seeing someone who was doing traditional CBT with me, and that was helpful. But then it got to a point where it wasn't anymore. And then honestly, I spent several months just decompressing all the stuff from training that I had been through. And that may have even took like 6 months of going like every week or every other week. And then I finally remember having this moment where I was like, oh, I have all these other things going on, but I hadn't had a chance to acknowledge them or feel them or have the support where I could face it together with somebody else, versus just trying to like sit and feel better or meditate, which can happen if you have the right support, but I hadn't had it yet. So ultimately, at some point, it wasn't the right fit with that provider, and I found someone who was a person of color. I had a good connection with them, but they were taking some time off, and the person they referred me to was trained in somatic experiencing. And I didn't pick them because of that, but very quickly in working with them, it felt very different for me. And one of the things I remember happening pretty early in working with them was them reflecting to me in a kind way that I was experiencing really high levels of dissociation, and I had no idea. And I like to be a high achiever because I'm a doctor, but dissociation was not the thing that I wanted to be achieving really highly in. And I was like, oh my gosh, I just was like, what? And I was so used to it that I thought, this is my personality. This is like a cute thing I do that I'm just like in my fantasy world sometimes. It helps me write. I'm a writer. But I wasn't seeing the costs of the way that it was happening. And I was like, how do I really trusted them. And I was like, what do I do? And they're like, well, we have to start really slow. Like, things like, can you tell me what the wall in front of you looks like? And I kind of feel sad thinking about it now because I really couldn't, like, I knew it was a white wall, but I couldn't like really see it. And so I had to start really small with things like, for me, taking things in visually is more challenging. But if I listen for sounds in the room, like right now, there's like a fan that's blowing, or I can hear my own voice, or I can feel it vibrating inside. Touch is more accessible to me. Like I can feel my sweater. I was very conscious of the textures I chose today. And it was just practicing those things in the beginning. And again, that happening in a relationship with someone else is a key part of that. So now, a few years later, I'm actually decided that it helped me so much that I wanted to learn more. And I entered the training to become a somatic experiencing practitioner. I think it was the fall of 2023. And I currently we're recording in the fall of 25, so I should be done in spring 26. But it's something that can be applied in real time as you're learning it. So so that's where I'm at. I still sometimes float off, but it happens with way more agency. Like I know the signs that it's happening. I'm able to decide if I want to do it. And I can also communicate to other people if that's going on for me or if I need support. So it's also, I just want to also be clear that healing doesn't always mean like everything, like all these things just stop happening and we just become like this perfect person. It's more like getting to know the things that happen for yourself.
I love that. And when we were preparing for this conversation, you talked about a grounding exercise that maybe you both did, because there is this, I think we've talked about this, Sophia, of like, Sophia, I don't get it. Like, what are you talking about body embodiment?
I mean, I would love to ask you, Raj, because I think in that conversation, I said, Raj, have you been to therapy? Like, I don't put you on the spot.
And I totally dodged.
You died.
Like, this hummus is so good.
Talking about basic comments.
I think the realization that I had was I'd done therapy, but it was very CBT based and somewhat entrenched in me. And, there's some, for expansive as healing needs to be, our Western healthcare medicine paradigm is quite narrow and specific.
Mm-hmm.
in that if you talk about mental health, number one, we're already categorizing what mental health is, but effective interventions are often cognitive behavior therapy or CBT
Right.
in what is evidence-based and what's accessible, and trying to expand into other therapies that also have evidence, but maybe not implemented widely, and thinking about what body-based work is. So I'm kind of, I get in my head a lot, and this is what I've realized a lot in my personal journey is I'm very abstract and intellectual a bit. So it's so easy for me to be disembodied. So your question of therapy, I've done it, but it's like met me where I am, which is sometimes not the right place, which is like all in my head of like analyzing and thinking about complex topics versus grounding myself in my body. And really when I felt truly in my body has been as I've tried to grow in things that I've wanted to do better, but it's just like communicating more intentionally or authentically. And I felt that it's only accessible if I'm present in my body. So it's sense of like feeling my felt self and being here and now. That's often something in mindfulness and meditation. So this accessibility of my body is often being in the moment and having that accessible. But I think what was hard for me to connect the dots was like how this translates into healing. I think there's a lot more awareness recently that trauma can live in your body. So it's not just something you experience and some thought patterns that, we need to change your behavior or like belief system like CBT to get over trauma, I don't know if that's the right phrase, but your body holds so much of this knowledge that needs to be worked through. So when I first learned it, it was so abstract still of like trauma lives in the body. I think I understand it. And then, as I said, my default mode is an intellectualization. So I'm like, okay, let's look at the studies. Oh, the studies show it too. Okay, there's more research. Okay, now I can believe it because I don't know if I truly believe it versus let me reflect on my own experience and what do I feel in my body? Oh, does this feel true? Is very unnatural for me because I go out and look for validation from, I don't know, well, either something that always resonated with me or what's been taught to me of what the scientific paradigm is, right?
I know we had talked about one, but I just want to throw out a question, if it's okay. You mentioned that there are things that you do, like there was an exercise you did with us to warm up before we started.
Yeah.
I'm assuming you're referring to stuff like that where you do feel like you're in your body. And then there's other times you are more in your head and you know that you're less present. Do you know what the signs are for yourself that you're here?
Do I have signs that I'm here and present? So my background, let me share a little bit on, I think I've gone deep into meditation, specifically Vipassana. Rachel, you're familiar with that too, where there is more maybe integration with body. And then people might have heard of mindfulness-based stress reduction, which is a lot of body scanning too. So there's some concrete ways that I've learned. And it's always, when I first realized it was kind of a shock of like, wait a minute, like I can feel my feet and the top of my feet, not like the bottom, but with nothing touching it. There's like something there.
There's something there.
There's something there. Because most of the time what I feel is contact with the external world, right? Thing touching me. But even without any external stimulus of like, oh, like I have a calf. I don't know, it's kind of a random part of the body.
Yeah.
Like there's just like parts of the body that I totally ignore on a day-to-day. Was my first experience of how and I've had this my whole life. I don't know. I think that's how brains work. You stop paying attention for something for a while and then it just forgets it's there. Right. So, and then there's like negative aspects of it. I reflect on my experience as a primary care clinician in our current systems, right? Where you work an entire day just trying to get through the day sometimes at the end of the day, I'm like, why do my shoulders hurt? I think I know why it hurts. But during the day, did I know I was like so scrunched up and typing all the time because I was so external facing. So there's moments like that. I think I've been more aware of my body. But your original question of, do I have clear signs of when I'm present? I think I'm shocked by how surprised I am still of like when I come back to my body of like, oh, I was away from it for this. Like it feels like there's a sense of foreignness in my own body. So I think the other piece that I wanted to bring up was you've had these deep, like personal journeys, and thanks for sharing that. And just a lot of vulnerability too, talking about yourself. When did you feel like this is helpful for others too, to maybe learn more about two different, I don't know if to call it two different types of care, but somatic experiencing and then compassionate inquiry, to share with others and sometimes directly with your patients when you felt like, I think I want to share this with others and learn more in that way?
Yeah, in some ways, I think it was from like the very beginning of medical school where I just had a sense of something being off. Like, what are we doing here? And I think there's sort of two interweaving pieces of that. It's both the kind of narrowness of focus of Western medicine, and that includes not including often the body and emotions, and that also includes often not including the social context. And so we're trying to care for people, but we're kind of just holding this very narrow slice of their life. I actually ended up reading a book during my 4th year of medical school called The Anticipatory Corpse, which is this like very dense, it's like related to like Foucault, but this exploration of Western medicine. And the kind of central argument is that like our knowledge of the body has always been based on dead things. So it's like we gained knowledge of anatomy through dissecting corpses, and we gained, we have this mechanistic view of physiology, the body sort of as a machine. And then in more modern times, we're understanding health through biostatistics and randomized controlled trials. But like where in any of that is an actual like human, and where is there like life and wholeness? So yes, I think there's a sense of something missing. And then being in family medicine, you're just faced every day with the complexity of people's lives. And in some ways, the frustration of how little the tools we have to offer are. So it's like often you're prescribing a medication or you're putting in a referral, but your sense is like this person with uncontrolled diabetes, like really what's at the root here is larger social structures, and also the ways that it's really difficult for them to care for themselves and care for their bodies.
That answers it. When did you feel like this is also missing in the care that I provide, not just for myself?
But as I've done this work, I really am convinced it's like nearly every patient you see in clinic, there are there's unprocessed emotions and trauma that is impacting their health and their ability to care for themselves. It feels like it's nearly universal.
Yeah. But for you?
Yeah, I would agree with that. I was at a training where the teacher shared that there's somewhere from 10 to 20% of people who are living with trauma, but our views are just skewed because of who we are with. And like, well, I don't know. I would be curious where that statistic came from, because I also feel like most of the people that I meet, and then if trauma doesn't resonate with people, I mean, there's dysregulation for different reasons. And some dysregulation is normal, like at certain times when our bodies are going through changes that are just a natural part of, our life through time. But the issue is like when it's happening in such a way that it's impacting like our ability to live as our healthy self, and when there is stuff below it that's things that we could work with. And I think I felt inadequate for such a long time in like having this awareness of like there's something else here, but I don't really know how to interface with it. And people are coming to me, and it doesn't mean like I have to fix, and fixing is a problematic viewpoint to have in the first place. And all of people's problems are not necessarily like things that I'm going to be able to help them with. But in primary care especially, we make so much effort to have knowledge about such a wide range of issues. We treat so many different things. And mental health issues might be the most common. But I was like, I have the least tools. And okay, like let's say we get a PHQ-9 and there's concerning answers. Like, then what do I do next? Like I have, referral to counseling and medications, and there's nothing wrong with that. And I think to have behavioral health that's available, that we can refer to, that's like well supported, and they are trained in this, that's great. And to some extent, we don't even have that a lot of the times. And there's like more and more cuts all the time to just that. But one issue is that a lot of patients, like they're like, just to come see you, their primary care doctor was a lot. And they're here, they trust you. And so the idea of having to go see somebody else is really daunting. It's more time off work. It's hard to trust new people. And again, that doesn't mean it's on you, but is there something that I can offer? And I felt this very acutely during like the peak times of the pandemic, because people were, so I think long-term issues that were going on just got pressed so much harder. And then plus all of the acute things going on. And I had my own things going on. And I was like, gosh, I really want to be better at this, because like, this is here. Like, I gotta have a response. Like, it's showing up over and over and over again. And sometimes when I've talked to people about the things that I'm learning, someone will say something like, oh, but how do you have the time? And I think sometimes there's a perception that to kind of go there with someone, it's going to tank your whole day. Like, it's going to mean you're going to have to totally drain yourself. You're going to have to spend like an hour. And actually, the more tools I've gotten, it's like, it's taking less and less time. And if anything, it's helping me feel like I'm not carrying all that burden myself. Because first of all, I know there's so many people out there. Like, I'm way more connected to a community of healing than I was before. Like, when I go for the SE workshops, there with other counselors or body workers or energy workers or whatever they may be. And I'm just like, wow, like there's really people out there really working every day to figure out how, despite all of this injustice, like, can we show up for each other? So being connected to that, having tools, and then being able to like speak the language of the body, like being able to read the signs that I can see externally, being able to help people get to know what's going on internally. I have found it to be empowering for myself, and at times frustrating, because I wish we could do even more, but at least there's something there that I can offer, and I get to have that conversation that I was always really wanting to have with people.
I love that. I feel like you answered a lot of questions. For this podcast, I think of so much of my goal is to build relationships and learn through that process. And then if other people are in a similar position, maybe they can learn too. And, I think of like, what could people be thinking of? And I've been on this journey for a little bit, maybe shorter than you all, of where I was initially thinking of what is embodiment, why is it important, and what can I do about it? The what piece I feel like is a little clearer. Maybe we can recap that in a little bit. But the why is it important? You talked about your personal journeys and then witnessing it with others. And for me, I feel like I don't focus on healing myself that much. But what led me to this topic was witnessing others suffering and thinking about what can I offer to them? What can I invite them in? Those two words I really love, and been thinking about that a lot, because we can't fix people or cure them. And sometimes, I'm sure people have an example. There's an antibiotic you can give for an infection, but generally in the care that we provide, we can offer options and invite people into spaces of healing. And the why piece that you called out that really resonated with me that I've been thinking about is all we can do is build maybe our toolkit, whatever you want to call, of options that we can offer to people, because it does feel so limiting when people are suffering and we're witnessing that suffering. And maybe with mental health, what we've been taught, we're all primary care clinician, is, hey, meds, referral to mental health.
Yeah.
And sometimes that's not enough, and for whatever reason. And maybe having this as a tool can be helpful for you too. And the thing that I'll add is, with this podcast specifically, I've connected with so many different communities, and so many communities have suffered through unimaginable trauma. Sometimes community-wide trauma, generational trauma. I think we all have, but with refugee communities, it's an intensity that I can't even fathom or imagine. And people have carried that through generations. And it seems so incorrect to say, oh, referral to mental health is the answer there. And when communities have found healing themselves, it's often with themselves relationally, and their body-based and energy work. For some communities, it's religion and feeling like there's something bigger, and that leads to gathering spaces too, whether it's Buddhism, Christianity, and I know that's all a lot to unpack just with religion, but finding ways of relational and body-based healing is what communities found for themselves. So trying to understand that has been a journey too, because in our medical school training, I never thought of that as a way of healing. It was so pharmaceutical based and people and cognitive based. I don't know if I can categorize therapy that way. Those are kind of the places that I felt like I needed clarification on. Maybe people who are listening also have been in those spaces of really feeling powerless. And that has been a really hard feeling for me too, of you're in front of me and I'm witnessing the suffering. I don't have anything to offer.
Right. Yeah. I was just listening to a podcast with Kathy Kane this morning, and she is a somatic healer who super amazing. And I really recommend her book, Nurturing Resilience. And she worked a lot with people who had chronic health conditions that were like the people that doctors were like, we can't help you. And she found a way to work with those patients and help them. And I think one of the things she had said was, or what I understood her to be saying was that telling somebody like, you can't be helped is different than like, I'm not sure what to do.
Mm-hmm.
Or, gosh, I wish I had the skills to help you. And I think that we're not taught how to, well, the way she put it was, it's always within your scope of practice to be human.
Mm.
And being human includes not knowing what to do. It includes making mistakes. It includes having to ask for help from other types of providers and asking for help from your organization. And so she also talked about how there's a lot of people who work within organizations that feel like they need more support. And I just had a conversation recently with somebody at work about this, but there's only more and more cuts over time. And then, at least in the current climate, and that hopelessness is kind of a form of secondary trauma, because hopeless is kind of like a traumatized state. So when I think about trauma, I think about the nervous system, and trauma is like an overwhelming event of which we weren't quite able to respond, or we didn't have the right support in order to be able to respond to it. And then in the aftermath, it is kind of a reverb that continues. Even though the event is over, we don't know it's over. And there's different ways to respond when you're in an overwhelming situation. There's fight or flight, and then there's also freeze. And one of the things I learned in the SU training was about polyvagal theory, where so fight and flight are kind of in that sympathetic response. And then parasympathetic, we learn in medical school, is like rest and digest, but there's more to it in the polyvagal view, where there's like the healthy rest and digest and relaxed social communication, but there's a different side of it that's that freeze response, that my fight and my flight were unsuccessful, so now I need to feign death. And in that there can be an apathy or a hopelessness, and then what we see in the clinic is a lot of the physiological signs of these responses. So if you're gearing up to fight, your blood pressure's higher, your heart rate, you're breathing faster, maybe your muscles are tensed and you're like ready, or you're, running away, you're prepared to run. Or if you're in this freeze response, maybe you have a low heart rate, or it's like you're, in my case, when I just like wasn't here a lot of the time, I had kind of like, that was its own form of fleeing, but there was some amount of freezing associated with that too. So my view is that these kind of incomplete survival responses, this is what we're seeing in the symptoms that we see in our patients. And so Kathy calls it survival physiology. And the survival physiology, instead of having a natural rhythm of like, okay, I charge up and I go back down and up and down, it's just kind of like stays in this fight or flight, or it stays in this, freeze, or there's both going full force at the same time, which can become very complicated. And so now when I see patients, I'm kind of looking at things differently than I did before. Like, when I see their vital signs, I'm not just thinking they need losartan. I mean, they might, and I'm I still support medications because people still need them on their way along the way. And I'm not an anti-medication at all. I use that. It's a very important tool. And why is their blood pressure high? Like, what's going on? And a lot of times it's like, oh, I took the bus to get in here. Yeah, that might be it. Yeah. It could be. Maybe you needed a minute, but maybe you've been in this response for 30 years. Or maybe you've been living with structural racism for decades, and we're never allowed to show your fight. And so, but your body is still responding, and now you're on 4 blood pressure medicines and none of them are making your blood pressure budge. And then, so like vitals are part of it, postures, gestures, the way people hold themselves, even for myself, I used to be very like, it was hard for me to really, because I had no sense of my own internal structure, and that so that kind of collapse positioning was what I knew. And so, and then there's all the things going on inside the patient that, my relationship with them involves helping them build that vocabulary. So education is a big part of it. I had to educate myself first before I can educate them. Education is probably the number one tool that I use with patients. And then it can be really simple things like, did anybody ever explain to you the connection between emotional health and asthma, or blood pressure? And oftentimes the answer I get is no. And so there's a huge opportunity there. So there's so much that actually we can do with people. I think sometimes we feel so overwhelmed, but like these little things really matter in my viewpoint. And the bigger context also needs to change.
Yeah. I love that. And a few things that really resonated with me is that I feel like whenever we start talking about body-based work, there's sometimes different camps of like, no medicines, we're doing body work, right? But you're like, oh, that might be helpful. That's what it's like, just like we can use anything we want right now. Yeah, we can do both of it. So there's not this dichotomy that sometimes where people are put into, and that makes people turned off too, of like, oh, roll my eyes. You're like, don't like medicines and want to work on quote unquote body, and being tongue in cheek when I say that. And the second piece that I wanted to call out, you talked about a big event in trauma, but so much what I see is, and there people might have that, is chronic dysregulation. And maybe they've had adverse childhood experience or something like that, but it's like living in these systems lead to chronic dysregulation, even if there's not a specific event.
Yeah. So, and I think Rachel has had a lot of training with the early developmental trauma, which I'm glad you mentioned that. It's weird because some of these things happen in our pre-verbal phases, but I don't know, Rachel, if you want to say anything about that.
Yeah, I think that's a really helpful thing to talk about, because we often think of trauma as like what you might say like big T trauma, like there was some big event, like there was sexual abuse or there was physical abuse, there was death or abandonment. But I think trauma, in the way that Peter Levine or Gabor Mate, whose work is kind of the inspiration for compassion inquiry, would say that, I think in a sense, trauma is anything that leaves you more restricted than you were before. And that might be mentally, that might be physically. And that can come in many different forms. And especially like when we're really young, when early in life, we're, totally dependent on our caregivers. And Gabor Mate talks about there's this tension between authenticity and attachment. And if there's anything in your environment that makes it more challenging to be authentic, and that could be, like thinking about in my case, like my mom dealing with like depression and anxiety and overwhelm. It could be, it can be much more subtle things. But as a child, you're always going to choose attachment over authenticity because the attachment is necessary for survival. And so it's vast majority of us didn't have perfect caregivers and perfect environments that we grew up in. That's like our culture doesn't support that. And so at some point I was going to say make a choice, but it's not even necessarily like a choice that you're making, but it just happens that you're going to choose that attachment over authenticity and you're going to lose some connection to yourself. And so I think it's near universal that we come out of childhood with some disconnection from our authentic self. And then in that disconnection, I think is where a lot of physical and mental health symptoms can come in. And in some ways, I actually think the distinction between those two is not really that real. Like, I think they're so closely intertwined. And I think this, Gabor Mate is often sort of critical of diagnosis in a general sense. And not that it's like not helpful and it doesn't give us certain tools. And so it's not that we like should throw it away completely. But when you're with an individual patient, it's really understanding not like, okay, do I give you a diagnosis of essential hypertension, but understanding what's going on in your life, what's going on in your history, where are there places of disconnect that now your blood pressure is elevated. So it's almost rather than seeing things as a diagnosis or a problem, you can almost see them as a invitation or a question, a place to get curious. Okay, what is this telling us, and how do we use this as a starting place to explore and move towards healing? So it gives like a different framework. And so I think you can think about all of these things as like trauma and disconnect, or if trauma is a loaded term, then you can just think about it as like, okay, we all have this disconnect from our bodies and emotions that that manifest in what we can call and label as many, many different diagnoses.
Yeah, or even patterns. Like, we all have patterns that we fall into. And I feel like getting to know the pattern a lot of times is more helpful than the diagnosis. And I spent a lot of time thinking about this because for some people, like, diagnosis is just really important to them. And the way someone explained it to me is like, for some people, provides like a container to understand their experience. And so similar to medicine, like a diagnosis is important to somebody, like, okay, but really where I can be helpful is in understanding the pattern. And then one of the other parts of it is consent. And so there's kind of like this non-spoken verbal contract that societally, that when you come to see the doctor, like, there's a certain thing that's going to happen. Like, they're going to tell you what to do and you're going to do it or pretend like you're going to do it. Maybe ask some questions, but don't ask anything that's going to upset the doctor. Us being curious, like, what is your goal? When you came in today, what were you hoping was going to happen? And that in some ways is like giving that agency, or kind of practicing agency with the patient. Like, what do you want for yourself? And then they get used to knowing that when they come in, you want to know, and then maybe they will start thinking about it. What do I want for myself? Maybe nobody ever asked them. Maybe in that attachment injury, that was just nowhere in the home situation at all. And then giving people options. So I try to ask people, I mean, and this is coming out of like a lot of missteps. I mean, not like medical errors, but just like the learning how to talk about this is so hard that there were so many days where I did it where I was like, God, I really wish I did that different. And so this is where I find myself now, like, 10 years after graduating from medical school. And so I encourage people listening, like maybe take like one of these things and just practice it and see how it feels for you and follow that. And if there's something else you want to practice, like take a little tidbit at a time. So yeah, like asking people like, we can talk about medications, and another option is to talk about like holistic healing, or to talk about how your emotional health might be related to this issue. Like, are you interested in information about that? And sometimes people say like, yeah, in general, but today I just wanted to know, like, I'm not dying, or I just wanted to know, like, there's not an emergency going on. And I'm like, yeah, you're fine today, or no, you really need to get this checked out, and that's it. And then just for the people who are saying no, just kind of every time reminding that, hey, this other thing is available. Like, do you want to talk about that? If you ever want to talk about that, or like, here's some resources if you want to read about them. Again, that's like practicing. A lot of the healing comes from being in touch with your own sense of choice, like your own yes and your no. And there's a lot of freedom in being able to choose. And so practicing that, embodying that. And that's another way where, like, if you're feeling really hopeless, realizing like how impactful you can be in that moment with somebody, modeling that, something that maybe they've never experienced in their life. And if you care about these social issues, like trying to convey that respect in that moment with that person. It doesn't mean all their problems will get fixed. It doesn't necessarily mean like the world is going to get fixed, but this is what we have. This is where we can work on things.
Yeah. That there's hope in that you can be impactful in that moment.
Yeah, it makes me think, going back a little bit, when you were saying when you're with someone and you feel sort of helpless or you don't know what to do. I think there's a really interesting reflection in that moment of, well, there's probably two pieces of it, is kind of exploring like, what is your own personal comfort with being in that space of not knowing, and also what's your comfort in being in with someone's deep distress. Because I think, and I'm speaking for myself here too, like I feel like as physicians, I think the thing that most keeps us from having these conversations with patients is because we're not comfortable with our own distress and emotions. And if we don't know how to hold that deeply for ourselves, how can we hold that? Of course, we're going to be nervous to like hold that well for someone else. And so I do think like, even if you don't feel like you don't need to like necessarily learn a bunch of somatic tools, though you can, and that's wonderful and helpful. It's like, if you're just doing that work of deep connection with yourself, that's going to make it, there's going to be so much more possibility in the room with a patient to just be in that space of uncertainty, to ask a question about something in their life. Like, I think an example for me, like, I feel like I've had conversations with folks about like sexual trauma. Like, if people will share stuff that I don't know that they would have shared before, because I think there's a sense of like, I have capacity to hold this. It doesn't feel as scary or overwhelming.
Yeah, I think that's so important. Thank you for sharing that. And I think that's a lot of where I started, was like, before I was practicing these tools, it was like, I had interaction and to feel right, and just journaling about that, like what was going on, and figuring out what was going on for myself. Like, I feel like I should have asked about this, like what was happening, and then getting support, like talking to friends like you guys, or whether it's a counselor or a mentor, because like we don't figure out how to do this on our own. But I think that sense of like, I know where I am, and I know what I'm available for, and I can be here with this other person. What a beautiful thing to be able to offer someone else. that's something all of us can do. And I think it's a continued process to work on that. Like, how am I when I'm with someone else? Yeah, that's a whole other, I actually have a training on that I just did with a group of nurse practitioners where we just practiced like, I'm here and you're there. And how do we be here together? And we spent 2 hours on that.
It's like so simple. I'm here and you're there.
Yeah, right. Yeah, my dad talks like that too.
Like, okay. But listen, try it out. Please.
But I do think it's an interesting practice. Like when you're with a patient, it's like, can I have 50% of my awareness on the patient and 50% of my awareness on me, what's happening internally and how, like you're saying, it's so easy to go through a clinic day and realize at the end of the day, like I was totally unaware of myself as an embodied person.
Yeah.
So how do you bring that into here?
Yeah. And I think of, just because you brought that up, of if I'm so unaware how patients maybe sense impatience or urgency, when maybe that's not my thing, but it's just because I haven't eaten and I'm stressed and that's coming up, but I'm so unaware. And how can I be there where you're there when I'm not here? Because there's a dynamic there that's established of opening, right?
I think there's an even more challenging piece of that to explore, which is also understanding, why are we doing healing? Like, why are we doing the work? Or why are we in a caregiving role? Like, why are we physicians? And that I would imagine, like, almost all of physicians, probably virtually all of family physicians, end up in this space in part from our own woundedness and what it gives us to be in a caring, healing, teaching, fixing role. And that there's actually things that we are wanting to get from patients.
Right.
Like we want to feel intelligent. We want to feel helpful. And that can be really uncomfortable to realize that I think I'm in this role of being it's all about other people. But most of us who want to be selfless actually coming from a deeper wounded place where, I don't want to spend time with what's in here, so let me try and fix other people. So there's, when you pay attention to your
comfortable.
Where are we going? Where are we going? Please.
But there's something, when you sit with that, it's actually really freeing because you can then make choices of showing up differently, letting that go. And then all of a sudden you actually you have a patient doesn't like you, or you don't know what to do, or they don't listen to your advice, or they don't like what you told them. And it just doesn't matter as much because you don't need them to feel good about yourself anymore.
Yeah. And that's how come it's not as people think it's draining to do this work, but it's actually less so because of that. Yeah.
Yeah. There's so many things I want to say, but it just made me think of all these retreats. I don't know if you've done it in your institution where people ask, why did you become X? And they're like, I wanted to help people. For one, I don't know if that's true or not, because everybody says the same thing. I mean, there's a deeper sense of why that we never get to. But the idea of, if you take it at face value of that's why they wanted to, the idea of a success in this interaction is if I was helpful. And then people's definition of helpful is different. And, you kind of challenged my original question of the why I wanted to have this conversation with the patient, and communities where I felt quote unquote powerless. And I felt powerless because of a goal I had, which is I need to help them in this 15 minutes and I'm not able to. And I'm looking and seeking, is there something out there that I can do? So then by 15 minutes, maybe it was helpful. And maybe that's not the goal. I mean, you still need to. I mean, I think this is worthwhile in itself. You can offer, but maybe you still can't help in that 15 minutes.
So in compassionate inquiry, the question I would ask you next would be something along the lines of when in your childhood did you feel helpless?
I was already sweating. Sorry.
You don't have to answer that. Sure. But that's question. But I can answer
that for myself. I was a very sensitive child And I felt very responsible for my mother's well-being. And so I had this sense of like, my worthiness in the world is contingent on making this other person feel better and be okay. And of course, that's probably part of why I went into medicine. And of course, I carried that into medicine. But it leaves me feeling bad if someone's not able to feel better. But of course, like, who wants to be like what patient wants your like feeling okay to be contingent on like how they're doing? Like, it doesn't feel good for the other person either, but I think it's like subtly present.
It's an interesting question to get to the why, because I think of, we'll go there, my childhood on, I grew up with my grandparents. My parents were a way of always demonstrating something of value, that I was good at things and I could achieve things, as a way of reinforcement that I was loved. So this feeling of what does it feel to get to that space is through proving some kind of impact or achievement in this like deep in me. And obviously that's not what patients want to feel like. I don't want their feeling to be like, I solved you, right? But there's also the other thing, part of like implicit beliefs and contracts, patients have that. And I think that reinforces this relationship of, I'm coming to you for help. You have knowledge that can maybe help me. And if I can do that, then I'm helpful and successful. So, and if we don't do that, we failed in that interaction. And sometimes both of us can hold that beliefs. And think of so much suffering with my colleagues and clinicians of difficult patients. That's a whole thing to unpack.
All different.
What is a difficult
patient?
Yeah. But there's this amorphous sense of, I wasn't able to help them. There's body-based symptoms that there's no diagnosis for. A lot of iterations around difficult patients, but connecting so many things here of like, maybe it's not so draining to understand this and be curious on these modalities of somatic experiencing or compassion inquiry to help you in those places that are currently draining for you.
Yeah, or just understanding like what maybe that person is in survival physiology, or this is their way that they manage, this is what helps them kind of feel safe to behave this way, but then also knowing your own limits and being able to like, what can you do in that situation? And one of the tools that I have found really helpful is Betty Martin's Wheel of Consent. Mm-hmm. And so she worked as a peer counselor and also a sex worker, and just in having had and lived in like communal settings. And so in relating to so many people, she came up with this wheel that breaks down interactions into 2 questions: who's doing it and who is it for? And depending on who's doing the action and who the action is for, that creates 4 quadrants: serving, taking, accepting, and allowing. And we often think that we're in service, but maybe there's something else happening and we think all we're doing is serving, but sometimes there's more nuance there to like, maybe I'm actually taking something from the patient, or maybe I'm allowing something to happen. And the basis for all of that is consent. So that's assuming that those interactions are happening in a way that we're consenting to. And I think that what happens a lot in medical settings is we're just running on scripts. We're running on these like pre-made agreements that we're not aware of. And we're just kind of doing things like robots. And oftentimes on both ends, it's out of those bounds. And so we're kind of getting into more shadowy areas of like, shadow service, which would be like, I'm serving, but actually it's because I need something. It's not coming from my heart that I want to do this thing for this person. I'm actually needing something out of this interaction. And if you care about social justice and you do care about communities that have been marginalized, it is super important for you to become aware of where you are in that spectrum, to know why are you doing it? Who is it for? And one of the things I've been learning about recently has been liberation psychology, which Ignacio Martin Barro was a Jesuit priest and a psychologist who lived in El Salvador. And there was a period of time of really, there's civil war, and it was a horrible time for that country. And his challenge to the whole science of psychology, the whole institution, was like, who is it for? Who is psychology in service of? And do we know, or are we just an extension of these neocolonialist, capitalist practices, and we don't even know, like, what we're just doing it because that's what we're in service of without any inquiry. So the more that we can ask ourselves, like, why am I doing this? Who is this for? What's driving my action? Where is the other person in this interaction? Is this what they're wanting for themselves? That becomes a dialogue with the other person. And that dialogue that you're in, that is like the place where we get free. And that's the place where we create a new reality together. And so it may be that in the past, this were the agreements that you had with your family of origin, or this were the agreements you had with the society you were in, but what's the new thing that we can make together?
Yeah. Let me see if I can bring this in, because I don't know if you all know, I think I told you I was at a conference. I didn't tell you the details. It's called the HLTH conference. It's a health conference. It's in Vegas.
Okay.
There's lots of strobe lights and unicorns. It's like Vegas. I don't know. Weird things like that. But it's essentially a healthcare tech conference where people have invested, in this room, it feels like almost like, oh, I can't believe I'm saying this, like billions and billions of dollars to solving healthcare problems. And it's interesting to think about what problems they're talking about, because connecting back to what you said a lot of who, and so much of healthcare feels like a what. Like, what is problem are you bringing to me, Sophia? And how can I solve that? So your problem is essential hypertension. And that is what we're solving together, not who in the room. So maybe this is a way to connect disembodiment too. You're not even a person. You just have a bunch of problems that we're solving. And that's what we're focusing on versus the relational dynamic dialogue that you're having with the human being. In this space, it seems so obvious. Obviously, there's a person in front of you. But I don't think it's obvious to a lot of people in healthcare that it feels like a business of solving problems, not being with people. And that can take you down a different route. And I think that feels different. And the last connection I'll make is, it's just funny because we'll actually have some episodes from that conference with people I interviewed. If you focus on the what, it can be like, I'm solving a problem of loneliness. And the solution to that is an AI voice agent that will call my mom and dad. And it might be helpful for them. Again, like any tool can be helpful for some people, but it's like a different starting place versus addressing something deeper of the loneliness that somebody's feeling that may be relational, maybe from childhood, maybe their expectations. There's so much to unpack there. Not that now you have somebody that's seems human that can connect with you and maybe dissolve that feeling of loneliness for you. I'm sorry I had to tell you that existed.
I'm mentioning a lot of different books, but I'm reading one right now by Dorothy Roberts. It's called Fatal Invention, and it's all about genetics. Mm-hmm. And genetics is a big industry. And so she's kind of going through how, like, this tech stuff, I mean, in that sense, it's specifically genetics. And is the money we're pouring into this ultimately making people healthier? And what questions are we asking? So what is not necessarily a bad question. It's just like, to what end are we doing this? And like, if we're bringing it down to tech, or, assuming that there's going to be a specific medicine for a specific gene that's going to correct a specific problem, that it's just like an awareness of where you're coming from. Like, is that where you're coming from with your questions? Or first of all, how do we build those questions together with our patients? Like, what questions matter to them? And that was what Ignacio Martin Bro did. He went to rural areas, and the people who really were not academics, were not, people with power. And he did surveys there and was asking people, like, to get a sense for, like, what's your reality? And I think this happens a lot for people this can happen in community health centers, where sometimes organizations come in that have money, they want to do a study, they want to figure out what's going on in your population. But it's like, we already know, like, people are struggling with poverty, or they need food, or they need housing, or, and sometimes that's just not as shiny as like a new tech thing or like a potential miracle drug. And again, I'm not saying that we shouldn't do any research into these things like at all, but the balance is so skewed. And I think it's so skewed that then our mindsets kind of get like carried away with that, because that's so predominantly the viewpoint. And when you're just marinating in that, you can start to forget these other things, these other questions. And I think you alluded to this, that you had these inklings that something was kind of not right when you were in medical school. But, the other noise is so loud that it's hard for that to get out. And so it's a practice every day. And so it's not that it's like just an awareness of like, what questions am I asking? Who is involved in those questions? To what end am I asking those questions? It's a conversation we have to be engaged in all the time.
Yeah, I mean, I appreciate you talking about consent, because I feel like that's so important. And you were talking earlier about how holistic care can actually be sort of a turnoff for people. You were kind of saying specifically because it can maybe be like anti-medicine and all of that. But I think the other piece of that is that within capitalism and within our like current healthcare system, like we often, I think it's hard to separate like health from capitalism and from productiveness and from like obligation. Like, you are a good citizen if you are healthy and productive. I think we can bring that into the room one-on-one with patients of like, you're a good patient if you do all of the things that I tell you, and if you have your diabetes under control. And so this feels like a little nebulous in my head, but it feels really important to separate out like deeper healing, which I think calls us into community. It calls us into connection with the earth. It calls us to challenge systems of oppression. It calls us to name systemic violence. And that's different from your body being the right way, or being able to perform, or all of these other things that we tend to measure health by, that are impossible standards for most everyone, but especially folks who are marginalized, because they've never been, and never in our current society will never be like a standard of health. So yeah, it feels like we have to be careful when we talk about healing and health, because I think it's come to mean something within capitalism.
Yeah. Your question of to what end, and the end is so you can work and be productive for the company. Then, health insurance is actually talk about that, days off from work. And if your provider group is actually doing a good job, that our employees aren't off work for that long. It's interesting how operational and systemic it can be, that belief.
And that's on the providers too. I mean, it's not just, are we trying to make our patients good workers who are not missing work, but also the providers are getting that same message.
Yeah.
Like, you're not productive enough. And I think that's why it's important to say, like, actual healing work is disruptive. Yes.
Because it might mean I'm going to make choices to be less productive.
Let me see if I can make this pivot, because I would love to answer the question of what is this, with all the different variation, multifaceted ways we've talked about it, and what can I do about it? So imagine I'm a patient coming to you, two different patients. Patient A has hypertension, diabetes, and hyperlipidemia.
Okay,
and
classic.
I'm just kidding. We see a lot of patients like that. My traditional approach to that is talk about exercise and nutrition, and then maybe talk about meds. Right? That's one. And I think, we talked about this, you hinted at like even nutrition, like what is like underneath that and behaviors. And I think some of this work comes into that. And patient B, I have body pain and we are ready to diagnose with fibromyalgia, and then, duloxetine doesn't have great evidence, but it's the only med we have. You're going down that path. So there's two different patients on, imagine this person's in front of you has never heard about body-based work. Like, how do you introduce the topic of like, what is it? And then like, how do you bring it into a space where it feels accessible and we're going to do something about it? And that could look different from compassion inquiry or somatic experiencing. And you can take your time and you can do the same patient if you want to.
Yeah, first step is relationship, getting to know. I don't have to know everything, but just like really basic, relational interactions. And then what do you want? What are you hoping? When you came in today, what were you hoping would happen? And if that person with fibromyalgia is having debilitating pain, it might not be that the first thing to do is, hey, let's really get in touch with your internal sensations. It might be really inappropriate to do that time.
Yeah.
So it depends. Like, is someone in a pain flare? Similarly, if somebody's blood pressure is super high or their blood sugar, their A1C is like 12, 13, 14, which is really common for us to see, might not be the day. So we do have a responsibility as physicians to make sure the person medically is stable, or at least we've done what we can to make sure that that's the case. And if there is acute pain, like, that needs to be treated the best that we can. But assuming that there's a relationship established, okay, there's some amount of trust there, then asking, like the consent that we talked about, I have some extra training and some other, healing modalities. Part of that involves looking at how emotional health is connected. And it really depends on the patient, because sometimes the way I'm saying it is so simple, and the question or the phrase that comes up, it just varies per the person. There's not an algorithm, it's kind of like a map or like a language that you have. So you kind of pick in the moment, but just getting a sense for if they even want to talk about the connection between these chronic health conditions and stuff that's happened, things that could have happened in their past or things that could be going on right now that are very overwhelming, and making sure it's not like, hey, you really need to look at your trauma, or, you don't want to say something like that's like that. And again, this is coming out of a lot of trial and error that I'm saying this. And sometimes the way it comes out, like you said, sometimes people just don't like what we're offering. They don't like us, or they don't like the situation, and they don't feel safe with us. Maybe they've been traumatized by so many medical providers that regardless of you offering something really beautiful, they still don't trust you, or they don't want to go there, or we don't know. And so I say that the relationship and then consent is really like the first thing that I would start with, and making sure you understand for yourself what they're hoping for. Is it clear to me what they want? If not, what can we talk about that? Like, what do you want to happen differently? Sometimes people just want to get their blood sugar under control so they can have a surgery. And then after that, it's not really of importance to them. And I need to make sure I know that. Then, assuming that they are interested, that we've built a relationship, they've come back, things are stable enough. There's so much education. Some of the people that, I think there's a societal education issue because of all the things we talked about, of like what we think is health. We think it's tech, and we think it's being perfect and all this stuff. So just so much time just on education of what health could be. What do you want? What is health to you? What does that look like? And then then after all of that, then I would start to work on how do we get to know what's going on inside.
I love that, because you talked about relationship consent. Is there any language that you use that seems accessible for folks when they're introducing the concept?
Yeah, I mean, I would say, um, what I said earlier, as far as like, has anybody ever talked to you about the relationship between, emotional health and physical health issues? Or sometimes if it feels appropriate, one that definitely I learned from Gabor work was just asking, what was it like when you were growing up if you had difficult emotions, if you were sad or you were scared or you were angry? And a lot of people, that was not an option to express that. And so if they didn't get the support to express those things when they were 3, 4, 5 years old, they had to come up with all this other stuff to do to handle those difficult emotions. And then 10, 20, 30 years later, all those things they were doing, now that's their blood pressure or their physical pain, because it could be that they were even physically bracing against those emotions over time. And if you started doing that when you were 4, because you couldn't say, I'm scared and get help, well, by the time you're 30 or 35, 40, you're going to have pretty intense physical pain. Potentially. That's one way it could show up. It shows up differently for everyone. And so I have to get to know for this person, what happened? What was it like for them really early? I think the biggest part in that, I think if someone's listening and you're hearing those questions, noticing right now what's happening in yourself when you're hearing me talk about this. What are you feeling inside your own body? What are you thinking about? Are you thinking this lady's nuts? Are you thinking, oh, I'm feeling some physical sensations? Explore that, because like Rachel said, like the primary thing is, are you comfortable? If you're not comfortable asking those questions, then don't start asking them until you are comfortable going there with people.
I'd really second, I think, really deeply listening, coming from a place of consent, or just getting permission. I think it's really important to feel like, for the person to feel like they're taken really seriously. And that might mean, like you might need to do medical stabilization. You may need to do workup. Like, it may not be the first thing that you jump to say, okay, let's do this somatic exploration. I think you can, but you have to be careful to make sure that that's not going to feel dismissive to people. Like you really need to hold and take seriously what they're sharing. But I think, simple questions are just like asking, like, what's going on in your life right now?
Yeah.
I really liked what you reflected, asking about childhood. I think another really interesting question that Gabor Mate offers, and this is specific to like addiction, but it can be any like behavior that someone's doing where it's maybe not serving them, is to ask, what is the function of this in your life? Like, what is this, smoking cigarettes, like when you smoke, what does that do for you? Like, what's the good things about it? People don't normally get asked that.
Right.
And most people know the harms. But really understanding, like, I think it really honors, like, we don't do behaviors for no reason. So if you're continuing to do it, there's something it's offering you. And so giving space to explore that so that people can walk away with more compassion. But I don't think people are going to change. I don't think we can change sustainably outside of a place of compassion for ourselves. Like, we can only force ourselves to do something for so long.
Yeah, it's thinking about, you were trained in spinning babies too. You're right. You know what spinning babies is.
Yeah.
But it is, like with this work too, I just imagine somebody being like, okay, all right, let me talk to you about somatic experiencing versus like using terms that are approachable. It's like when my prenatal visit, like, I'm going to talk to you about spinning babies. Like, what are you going to spin? Like, why? Versus like, I really think your body is important in this process too. And, I've been trained in things that honors that body-based work and acknowledge its importance in delivery. So not maybe latching on to the term itself, because that helps you get trained in it. But maybe to our patients, it's not this whole new field we have to educate them on in an encounter of, let me talk to you about the differences between somatic experience and compassionate inquiry, like, what would you like, kind of thing. But just this idea of meeting them where they're at, and then you being trained in these modalities as a tool to bring it in, maybe. Does that sound right to you? Or is that landing?
Yeah. And I think with more time, it's become more subtle for me. I mean, the goal for that to become even more so over time. But like sometimes just like when I can walk in, I can just see the grief like before I've even talked to this person. And so just from when we walk in, just how we are, how are we meeting the energy that they have at that time? And like, you just know sometimes something's going on. And, you know, I've had some patients I've worked with where it was like 2 or 3 years before I got actually the story about what was going on at that time. And sometimes for some people, it wasn't until after they were feeling better that they were like, actually, this happened to my family member. This was happening to me. And so also not like pushing for it, like just showing up and showing that you care. Like eventually sometimes the story comes out. And other times it comes out right away. People share right away what's going on with them. And then for some people, like the education doesn't have to be that long. Like I saw a patient the other day who they were having knee and back pain, and they had had a fall before, and they were getting in physical therapy, and it was feeling pretty good for them, but they would get this fear like when they would do certain movements. And so we just did like a quick exercise around, well, when you're here and you're on solid ground, how does that feel inside for you? And I have like a chart that has feeling words, and he just took it and he read it, and he just spent a few minutes and he was like, I feel solid, I feel safe. And then, you know, kind of building up that sense of safety, and then acknowledging, well, when you're in this other situation, how do you feel? And so just building that vocabulary together. So it's not a one size fits all. The most that you can do is just like try to acknowledge people have a lot going on, and your presence with them, regardless of your skill level, matters a lot.
I think pausing to name what you're seeing, like you reflected on that, just to say like, you might be in the middle of the visit and say, well, it seems like there's some emotion coming up for you, or like, it seems like something's not going well, or maybe I'm missing something, and just giving space. It's like letting patients know it's okay for that to come into the room, because I feel like a lot of folks are like, it's like, how many times has someone apologized to you for crying in a like they feel like they shouldn't be bringing that. That's like disruptive to you.
Maybe the last question, or one of the last questions, people ask about recommended resources, but let me reframe that on who has influenced you in your journey. And it can be like people, and maybe there's resources that they have developed or created for others that you feel like is important to share in this space. And that could be different for both of you, or same, you know, Gabor Mate comes up a lot.
Yeah.
But yeah, I want to hear from you all.
Yeah, I can share. I will say, so the book I mentioned earlier, The Anticipatory Corpse, I'm like hesitant to recommend it to anyone because it's super dense, but that was fairly transformational. It's on my list to someday read again. Gabor Mate, who has a number of books out there, I think his way of thinking about trauma has been really influential. Peter Levine as well, and really kind of connecting to the body, and this idea of titration, taking things slowly, has this idea of pendulation, where you're kind of connecting places of ease with places that are more uncomfortable. I think those have been really profound ideas for me.
What about you, Sophia?
I just made a website, which was really hard for me because I'm a very private person. But the reason I'm mentioning it, so drsophiamalik.com, I'm mentioning it because I put my favorite resources on the website. So if you go to the blog, I have a list of like some of my favorite like podcast videos I've watched, books I've read. So you can find more of them there. And I'm hoping to have a newsletter. So I don't have one yet, but you can sign up. And when I have one, I will send it to you. But I mentioned Kathy Kane's book, Nurturing Resilience. I think that's a good one that goes through attachment and the nervous system stuff. And it's written in a way that's very, I didn't find it to be like too like dense. Like I found it to be approachable and has some case examples.
I just thought Resma Minicum was probably the first who wrote the book, My Grandmother's Hands. That was probably the first person who I actually heard explicitly talk about somatic work.
I feel like
I think that's really powerful.
He brought awareness about the idea because it became popular. Not that other people haven't been doing that work, but I heard about him a lot. Well, thank you for your generosity in sharing your journeys and vulnerability. I think, I started this conversation or wanted to have a better idea of what you all have been doing, but also trying to help others figure out what's missing in healthcare, because everybody has a feeling something's missing, but really reflecting back and hearing your journeys, but also helping others understand these different modalities, I'll say, in a way that can be helpful for them to offer in their journeys too, has been super helpful, and for me too. So thank you.
Yeah, thank you, Raj.
Thank you, Raj.
I think